Okay, let's unpack this. We're taking a deep dive into a stack of notes here, specifically looking at a condition that maybe a lot of people haven't heard of, but for those who have it can really impact their life significantly.
Meniere's disease.
Exactly, Meniere's disease. And our mission today, for you listening, is to turn these, well, they look like revision notes, probably for something like the MSRA exam,
Looks like it.
into a really clear, high-yield understanding. We're sticking strictly to what's in these notes about the condition.
Right. Think of it like we're highlighting the key bits for you. We've got the basics, what it is, potential causes right through to symptoms, diagnosis, management, and the longer-term picture.
What to expect, yeah.
And Meniere's has some, very distinct features, so understanding the mechanics, as laid out here, is pretty crucial.
Absolutely. We'll guide you through, pull out the important stuff. So let's start right there. The definition. Based on these notes, what exactly is Meniere's disease?
Okay, so the notes define it as a chronic inner ear disorder. The absolute key thing is these recurring episodes of symptoms.
Recurring episodes, okay.
Yeah. And when an episode hits, it's usually a specific mix. Intense vertigo, that feeling of spinning.
Right.
Sensorineural hearing loss, so damage in the inner ear or the nerve. Tinnitus, which is often described as like a roaring or ringing sound. And this feeling of fullness, like pressure, deep inside the ear.
So it's that cluster of things happening together, and it comes and goes.
Exactly. Unpredictably.
Yeah.
And the underlying issue described here, the reason for the symptoms, it's an abnormal buildup of fluid in the inner ear.
Fluid buildup, okay.
Yeah, leading to too much pressure and swelling within what's called the endolymphatic system, part of that inner ear structure.
Got it. And who usually gets this? Any demographic info in the notes?
It says here it occurs most often in middle-aged adults,
Yeah.
sort of 40 to 60 is the typical range. But importantly, it can affect any age and any gender.
Okay, so we know what it is, chronic inner ear fluid buildup, these episodic symptoms. But the big question, and maybe the tricky one, if it's fluid buildup, do these notes explain why? Why does the fluid build up? The cause, the etiology?
Yeah, this is a really key point the notes emphasize. The exact fundamental cause, still largely unknown.
Right. Frustrating.
It is. It's described as complex, an interplay of different factors. So we know how the fluid causes the trouble, but not really what kicks off the imbalance in the first place.
What kind of factors are mentioned then? What are they looking at?
Well, the notes list a few possibilities. Things like just a general fluid imbalance in the inner ear itself, maybe abnormalities in the immune system.
Immune system, interesting.
Yeah, potentially genetic factors too. Does it run in families? And viral infections are also thrown in there as potential triggers.
And were there some other, maybe less certain ideas mentioned too?
Yeah, the notes briefly touch on links with allergies, maybe past head trauma or other autoimmune conditions. But the connection there might be, let's say, less established than the others.
Okay, so the why is fuzzy, but there are leads. What about risk factors? Things that might make someone more likely to get it, according to this source.
The notes list several things that seem to increase the risk. Having family members with Meniere's is one.
Okay, the genetic link again.
Right? And also a personal history of migraines. That's mentioned as a significant risk factor.
Migraines. That seems unexpected. A headache disorder and an inner ear thing. Do the notes explain that link?
They don't really detail the mechanism for the migraine connection, no. But it pops up often enough in the literature that it suggests, maybe some shared pathway or susceptibility that we don't fully grasp yet.
Huh.
Okay.
What else?
Other risk factors listed are existing autoimmune disorders. Rheumatoid arthritis and lupus are specifically named here. Then tying back to the possible causes, allergies, including food allergies, are associated. Potential past viral infections. And like we said, just being in that typical age bracket, 40 to 60, because that's when it usually starts.
Got it. Okay, let's circle back to the mechanism, the pathophysiology. If it is this fluid buildup, how does that pressure actually cause the spinning and the hearing loss? What's happening inside?
So the core concept in the notes is something called endolymphatic hydrops.
Endolymphatic hydrops, okay.
Which basically means an abnormal buildup of a specific fluid, the endolymph, inside the inner part of the inner ear, the membranous labyrinth.
Hydrops.
No.
Sounds like water swelling.
Pretty much, yeah. Excess fluid literally stretches or swells these delicate structures. Now remember, the inner ear has, broadly, two jobs. Hearing, via the cochlea, and balance, via the vestibular system.
Right, hearing and balance.
And this hydrops, this pressure, it disrupts the normal function of either the vestibular part, causing the vertigo, or the cochlea, causing the hearing loss. sometimes both.
Ah, so that directly links the fluid to the specific symptoms you get.
Exactly. The notes also mention that sometimes this pressure can cause tiny ruptures in the membranes inside, mixing fluids that shouldn't mix, which might worsen things, and could possibly link back to those immune factors mentioned earlier.
It's a very physical process then, the swelling interfering with the nerves.
Precisely. It physically messes with the signals about sound and where you are in space.
Okay. Before we dive deep into the symptoms people actually experience, how common is this? What do the epidemiology notes say?
The source gives UK figures, suggesting around 2 to 20 cases per 100,000 people.
So, not incredibly common then.
No, relatively rare overall.
Hmm.
It's noted as being slightly more common in women, and like we said, onset usually 40 to 60, and it gets more common as people get older.
And does it always affect just one ear?
Usually starts in one ear, that's unilateral, but the notes say it can develop in both ears over time. Those are bilateral cases.
Right. Okay, let's talk symptoms. The clinical presentation. This is crucial because the notes say there isn't one specific exam finding between attacks, so recognizing the pattern is key. How does it typically show up?
The absolute number one symptom, the hallmark emphasized here, is that episodic vertigo, and crucially, the duration. The notes stress these spinning attacks last for hours.
Hours. Not just a brief dizzy spell?
Definitely not. Not like, say, BPPV, which is usually seconds or maybe a minute. This is prolonged, intense spinning.
Wow, that sounds awful. That duration must be a key clue.
It's a huge differentiator. Alongside the vertigo, you get the other core things. That fluctuating sensorineural hearing loss. The hearing can kind of come and go or worsen.
Fluctuating, okay.
That distinctive roaring or ringing tinnitus, and the aural fullness, that pressure feeling in the ear.
And these episodes, they're just unpredictable. They can happen anytime.
Yes, the notes highlight the unpredictability. And the vertigo is often severe enough to bring on nausea and vomiting too, which, just adds to the misery.
Oh, definitely. What other features might someone notice?
Well, the notes list the recurrence these symptoms keep coming back. The ongoing aural fullness. During an actual attack, you might see nystagmus, that's involuntary eye flickering.
Right, the eyes moving on their own.
Yeah. And the notes mention a positive Romberg test might be seen. That's where you stand with feet together, eyes closed, and if you sway badly or lose balance, it suggests a balance pathway issue.
So during an attack, swaying, maybe eye flickering, and just to hit that duration point again, the notes say minutes to hours for an episode.
Correct, and it usually starts unilateral one ear, but can become bilateral later.
The notes also mention a memory aid, the classic triad. What's that? Useful for revision, I bet.
Definitely useful.
Yeah.
The classic triad highlighted here is tinnitus, hearing loss, and vertigo. Easy 3 to remember.
Tinnitus, hearing loss, vertigo. Got it.
Then the notes add the other common things to keep in mind: nausea, vomiting, aural fullness. And they also mention something called drop attacks, though they say these are rare.
Drop attacks, what are they?
It means suddenly falling to the ground, just collapsing, but without losing consciousness. It can happen in some severe Meniere's episodes. Uncommon, the notes stress, but serious if it occurs.
Okay, so that paints the picture of how it presents. Given how dramatic this sounds, how do doctors diagnose it? Are there specific criteria in these notes?
Yes, there are diagnostic criteria outlined. To diagnose Meniere's, the notes say you need at least 2 spontaneous vertigo episodes, each lasting 20 minutes or more.
20 minutes or more, specifically.
Yes. And crucially, you need objective proof of hearing loss on a hearing test, an audiogram, linked to at least one of those episodes. Plus, you need to have experienced tinnitus or aural fullness in that ear.
So it's quite specific. Vertigo, duration, hearing loss confirmation, and the other symptoms.
Exactly. And while an ENT specialist usually confirms it, the notes say primary care often handles the acute attacks.
What about the physical exam? You mentioned it's often normal between attacks.
That's right. Between episodes, not much specific might be found. But the notes advise doctors to do a good check. Check cardiovascular, neuro, ENT exams to rule out other causes. Check for anemia, blood pressure weirdness, cranial nerves, look at the eardrum, maybe check for BPPV.
But during an attack, maybe things are visible.
Yes, the notes list things you might find during an acute episode. Observing that nystagmus, the eye movements, documenting the hearing loss, though the formal test is usually later, maybe doing tests like the Unterberger step test.
Marching on the spot with eyes closed.
Yeah, seeing if you rotate
Yeah.
suggests a balance issue. And interestingly, the notes specify a negative Dix-Hallpike test.
Negative Dix-Hallpike. That's the test for BPPV, right? So it's negative.
It points away from BPPV and makes Meniere's more likely. Since Meniere's is fluid pressure, not loose crystals like in BBBV. That test shouldn't trigger the vertigo, so it's a useful differentiator mentioned here.
Clever. The notes also mention the Gibson Point System and AAO-HNS guidelines.
Right, the AAO-HNS are formal diagnostic criteria. The Gibson Point System, as described here, sounds like a structured scoring method. It gives points based on symptoms like vertigo duration, hearing loss association, fullness, tinnitus, basically a systematic way to apply the criteria. Helpful for structuring your thinking, especially for revision based on these notes.
Helps make sure you cover all the bases from the history.
Exactly. Formalizes it a bit.
Okay, so beyond the symptoms and exam, what investigations do the notes recommend to confirm and rule things out?
Key investigations listed are pure tone audiometry. That's the standard hearing test to measure hearing thresholds and see the pattern of loss, which is often low frequency initially in Meniere's.
Essential for the diagnosis criteria anyway.
Absolutely. And ruling out other things is critical. So the notes strongly recommend an MRI brain scan, usually with contrast.
Why the MRI?
Mainly to rule out things like an acoustic neuroma, a type of brain tumor on the hearing, or balance nerve, or other structural issues that can mimic the symptoms. Very important differential.
Makes sense. You wouldn't want to miss that. Any other tests mentioned?
Electrocochiography, ECOG, is listed. It's a specialized test measuring electrical potentials in the inner ear. Can sometimes show evidence of that endolymphatic hydrops.
Okay.
Other things mentioned are blood tests, just to rule out systemic illness. Maybe video nestomography, VNG, for detailed eye movement analysis. Brainstem auditory evoked potentials, BAEPs, to check the auditory pathway.
Sure.
And maybe mastoid x-rays or CT scans to look at the ear bone structure.
Seems like a thorough workup, to be sure.
Yeah, given the symptoms can overlap with other conditions, these notes emphasize being thorough.
So once Meniere's is diagnosed, based on all this, what about management? What can actually be done? What do the notes say?
Okay, management goals here are basically twofold. Relieve symptoms when an attack happens, and try to reduce how often the attacks happen.
Relief now, prevention later. Makes sense.
Exactly. So the notes list several strategies. Lifestyle and diet often come first. Salt reduction is heavily emphasized.
Really? Cutting down salt.
Yeah, the notes highlight that as a key recommendation. The idea is it might help manage fluid balance. Also, avoiding other known triggers, caffeine, stress, things like that, which can vary person to person.
Salt reduction. Sounds simple, but maybe hard in practice.
It's a common first-line suggestion. Then, medications. For acute vertigo attacks, the notes specifically mention prochlorperazine helps with the nausea and spinning.
Right, an anti-sickness type drug.
Yeah. And for prevention, for prophylaxis, a drug called beta-histine is listed. It's thought to improve inner ear blood flow or fluid regulation.
What about the lingering balance problems?
Vestibular rehabilitation exercises are mentioned. These are specific exercises to help your brain adapt to the faulty signals from the bad ear, improving overall balance.
And other support.
Counseling is noted as important because living with this unpredictable condition can cause significant anxiety or depression.
Understandable.
And hearing aids are crucial not just for the hearing loss, but the notes mention they can sometimes help mask the tinnitus too.
Ah, that's useful. Now, there was a really critical point in the notes about driving.
Yes, absolutely vital practical advice here. Because the vertigo can be sudden and totally disabling, the notes state you must inform the DVLA, the driving authority in the UK, and you have to stop driving until the symptoms, especially the vertigo, are properly controlled.
Wow, that really underscores the severity and the risk involved.
It does. It's a major practical implication.
What if the attacks are really bad, can't be managed at home?
For those severe acute episodes, the notes say hospital admission might be needed, maybe for IV fluids or stronger medications.
Okay. The notes also list some other treatments, non-pharmacological or more advanced options for tougher cases.
Yeah, these are generally for people whose vertigo is still debilitating despite the initial measures. Options mentioned include the Meniere device applies little pressure pulses to the ear.
A device, okay.
Then surgical options.
Oh.
Things like endolymphatic sac decompression surgery trying to relieve the fluid pressure, intratympanic injections.
Injections into the ear.
Yeah, through the eardrum. Usually corticosteroids, which are anti-inflammatory, or an antibiotic called gentamicin.
Gentamicin, an antibiotic.
Yes, but used here because it can selectively damage the balance cells in the inner ear to stop the vertigo. The downside is it carries a risk of worsening hearing loss.
Ah, a definite trade-off then. What other surgeries?
More definitive destructive options for really intractable vertigo include vestibular nerve section, cutting the balance nerve, and labyrinthectomy, removing the inner ear balance and hearing organs on that side, usually only if hearing is already gone.
Those sound like very significant interventions, last resorts, presumably.
Absolutely. Reserved for severe, disabling cases unresponsive to other treatments. And the notes add that after surgery, more vestibular rehab is often needed.
And hearing aids keep popping up throughout.
Yes, the notes consistently reinforce managing the hearing loss and tinnitus, often with aids.
So looking long-term, it's a chronic condition. What did the prognosis notes say? What's the outlook?
It is chronic, yes. But the notes actually offer some positivity. The majority of patients, it says, can manage symptoms effectively with treatment and lifestyle changes, maintain a decent quality of life.
That's good to hear.
But it also says the severity and course vary a lot between people. Some might even resolve spontaneously, though that seems rare. Others stabilize.
How do the symptoms themselves tend to change over many years? Is there a pattern?
The notes describe a typical progression. Early on, lots of fluctuation in hearing and vertigo. Over time, the hearing loss often gets progressively worse and becomes more permanent. The tinnitus can also become more constant.
Okay.
But interestingly, the notes suggest the frequency and intensity of the vertigo attacks often decrease over many years.
So the spinning might get better, but the hearing and ringing stick around or worsen.
That seems to be the general pattern described here. The vertigo might even burn out or resolve after maybe 5 to 15 years. But the notes caution, even then, the hearing loss, tinnitus, and fullness often persist.
It really sounds like something that evolves over a long time. Finally, complications. What are the wider impacts beyond the main symptoms, according to these notes?
Well, the notes are clear. The unpredictable nature of it all has a big impact on quality of life.
I can imagine.
The psychological impact is significant. Anxiety and depression are noted as common, which makes sense, living with that uncertainty.
Totally.
And functional issues, problems with balance, coordination, even between attacks, that can limit work, social life, daily activities, and again, that major practical complication, the risk of losing your driving license because of the sudden vertigo, that's a huge potential consequence highlighted.
Yeah. It's clearly a condition that goes way beyond just the ear itself. Affects everything.
It's the whole burden of living with something so disruptive and unpredictable.
So, thinking about Meniere's, we know what the fluid buildup, the hydrops, and how that pressure causes the symptoms, but that fundamental why, the root cause, is still missing. How does that gap, between understanding the mechanism but not the trigger, shape how we manage it? It seems to force us focus purely on controlling the symptoms and managing lifestyle, doesn't it? Because we can't yet fix the underlying problem. That's really something to mull over.
It absolutely highlights the challenge.
Yeah.
It underscores why symptom management, patient support, and ongoing research into those potential triggers are all so important when that fundamental why remains elusive.
Yeah, definitely. Well, that wraps up our deep dive into Meniere's disease based strictly on these revision notes we had. We've gone through the definition, the possible causes, risk factors, the pathophysiology, that fluid buildup.
Endolymphatic hydrops.
Right. How common it is, the classic symptoms that triad is useful, diagnosis, investigations, all the management options from diet to surgery.
Prognosis, complications, the whole picture is presented here.
Exactly. Our goal was to really boil down these notes into something clear and high yield, hopefully useful for your revision, maybe if you're facing exams like the MSRA.
Yeah, things like remembering that classic triad or the diagnostic criteria points, the duration of vertigo. Those are the kind of high-yield facts these notes are good for consolidating.
We hope this has been helpful for your own learning journey. And if you are using resources for MSRA prep, the notes mentioned passthemsra.com and freemsra.com. Resources like those offering structured learning and practice questions can be really valuable.
Absolutely. Reinforcing these key points and testing yourself is a great way to prepare.
Thanks for joining us for this deep dive into Meniere's disease. We'll catch you on the next one.